Welcome all. It is wonderful to have so many of you on our webinar today on adolescents and young mothers affected by HIV. My name is Alice Armstrong, and I'm going to facilitate today's webinar. I'm the adolescent and HIV specialist in the UNICEF East and Southern African Regional Office. It's my pleasure this morning to invite our Regional Gender Advisor, Emanuela, to extend a warm welcome to all of you for this webinar. Over to you, Emanuela.
Thanks, Alice, and good afternoon to everyone. It's a pleasure to be with all of you, and that's fantastic to see the number of people connected and the interest and support for young mothers living with HIV. I'd like to start with two striking data about our region. We have in Eastern and Southern Africa one of the highest adolescent pregnancy rates in the world. If we look back at 2019, 1 out of 4 young women gave birth before the age of 18. And at the same time, nearly 1 in 3 new HIV infections occurred among adolescent girls and young women. So as a result, this means there is a significant number of young mothers living with HIV. And we know, unfortunately, that despite the good work done by PMTCT, adolescent and young mothers have poor maternal health and HIV outcomes as compared to older women. This was the main motivations behind the report that we are discussing today. UNICEF has been benefiting from the tremendous support of the Swedish government as part of the Together for SRHR initiatives, and we work and partner with governments in the regions to build evidence on what strategies work better to address the complex needs of adolescent and young mothers living with HIV. So what did we find out as part of this programmatic review? And I hope you had the chance to read this review. Otherwise, it's available online, and we're going to share the link later in the chat box. So we've highlighted 6 strategies that I'm going to share with you now. The first one is the importance to include the unique needs of adolescent and young mothers in national, but also in district level strategies and plans. Secondly, generating but also using evidence to inform policies and programs will help us better understand young mothers' experience with HIV and motherhood, and that will increase the effectiveness of piloted interventions. It's also key to improve age-responsive service delivery approaches, to strengthening social support, primarily through peer community providers, and address multiple needs through multisectoral linkages and partnerships. Finally, the 6 strategies we wanted to highlight to you is the importance to plan with and for young mothers, especially to reach them in humanitarian settings and emergencies. We'll now hear from researchers, practitioners, and implementers on their efforts to achieve and sustain quality intervention at scale. Thank you.
Yes, Emanuela, thank you so much. We really have a great session planned for today. We're going to start off with setting the scene to try to understand more the lived realities of the adolescent and young mothers that are affected by HIV in our region. We'll then look to exploring some of the effective models that are being implemented. Then we'll have a panel discussion with all our fantastic invited guests. And then finally, we'll have closing remarks from Loie Goulet, our regional HIV advisor. We want to make sure that all of you are engaging throughout this webinar. So we've set up a Jamboard. I hope many of you have used a Jamboard before. If not, there's some instructions there on the screen for you. You just have to click on the sticky note and then add your experience. So your experience of whether you yourself are an adolescent or young mum, or if you in your position, you are supporting adolescent or young mums. Just an opportunity for you to share some of those experiences with the rest of the group today, just beyond the normal core chat, just another platform for you to engage on. So what better way to start this session is by hearing from young women themselves. This video includes 3 young mothers who are living with HIV, and they recently joined the Y+ and CCABA Young Families consultation.
My name is Robin Ababidia from Uganda. I'm a mother of 1, a baby boy. and I was born with HIV.
Everyone, my name is Linoche Damini. I am 22 years old. I'm working with Eswatini Network of Young Positives.
My name is Asasha Miriam. I'm 20 years old and my child is 5 years old.
What I love the most of being a mother is breastfeeding and watching my child growing healthy and strong.
You become sympathetic, you become loving, caring, and even learn how to handle difficult situations.
You get to see them walk, you get to see them make their first step, you get to hear them speak their first word, and it's really so exciting.
The biggest challenge that I faced when I was pregnant and as a person living with HIV was stigma and discrimination. I was verbally abused by the community, and whenever I used to go to the hospital for antenatal services, they asked me for my spouse, and of which the father to my child had already disappeared. He feared responsibility and he feared to be imprisoned because I was young. So I was discriminated and struggled with that by the health workers. So that gave me a hard time, and I even felt like not even taking antenatal services anymore.
The stigma that was attributed to being a single mom. For example, I am an advocate. People look up to me and they get to see that, oh, if Robna has done this, then I can also do this. So here I am, I'm pregnant. My boyfriend has broken up with me. So I'm at crossroads, I don't know. So that is the kind of stigma that you get. You know, people think that, oh my God, you're going to be this, you're going to be that. Oh my God, you're going to be a mother, you're going to be a wife. But then reality hits you that, oh no, things don't turn out to be the same.
I have to make sure I don't transmit HIV to my baby, and also how to provide for her.
Twin sister has been my biggest support, and as well as my close friends, because they came in at the right time when I needed them the most. I was in a series of depression. I had developed a lot of self-stigma after the breakup, so they kind of came in and filled the voids.
What have helped me as a young mother is getting support from my partner by providing all the needs of the baby, and getting support from my family, especially my aunt. I sometimes got mentoring from my peers within the network.
My grandmother was the most important and supportive person when I was pregnant, because when I couldn't hold it anymore, she took me to a church-based organization where there were more young girls like me. So I felt at place. They nursed us very well and there was no stigma.
Thank you, Rabina, Miriam, and Marcia. I love how your face lights up when you mention what you love about being a mother. It's really beautiful. Next, we have Teresa Alwa. Teresa is an adolescent and HIV specialist whose area of focus is adolescent-centered and adolescent-responsive HIV programming at the UNICEF Kenya country office. Today, Teresa is going to be presenting the findings of a qualitative study on the drivers of pregnancy among adolescents. Thanks so much, Teresa.
Thank you, Alice, for the warm welcome. And a good morning, good afternoon, good evening to all colleagues who are here with us today. In my presentation, I'll be sharing a little bit about Homa Bay County, the study objectives, the methods, as well as some of the key findings that emerged from this situation analysis on unintended pregnancies and HIV amongst adolescents and young people in Homa Bay County. Homa Bay County is situated in the western part of Kenya and forms part of the Lake Basin Economic Bloc. It is therefore representative when it comes to issues of size and world. The province has a high HIV prevalence of 18.5% in comparison to the 4.5 national average. In this county, women bear the brunt, with their HIV prevalence standing at 22.5% compared to 14.1% amongst their male counterparts. According to the Kenya Demographic Health Survey, done in 2014, a third of the girls were already identified to be mothers or were encountering their first pregnancy, and this was at the age of 15 to 19 years. much higher in comparison to the national average of 18%. In Homa Bay County, it is estimated that about 16,474 youth aged between 15 to 24 years are living with HIV, which means that in every 10 youth living with HIV, one is from home. Our study objectives were to understand the drivers of unintended pregnancy, HIV, and violence amongst adolescents in Homa Bay County in Kenya, to explore the economic, social, legal, and associated challenges, and to explore the policy and legal landscape in government and partnerships required for SRHR violence. This was a qualitative study combined with a literature review, and it was carried out in 2 sites representing an urban and rural setting in which a total of 112 respondents, who included adolescent parents, their caregivers, service providers, administrators, teachers, and youth leaders, were interviewed using various tools. Some of the drivers that contributed to early pregnancy, violence, and HIV included harmful norms, risk exposure, and risk-taking behavior. Amongst the norms identified, it was noted that adolescents had their first relationships or sexual debut from as early as 12 years for those in the rural settings and 14 years for those in urban settings, and this was true for both boys and girls. First sexual encounters were largely with age mates and were deemed as consensual. This would happen in the school setting or what were known as disco matanga. A disco matanga is when the community gathers for an all-night wake of a deceased person at their home as part of the celebration of life. As this was a study that was done during the pre-COVID period, this was a norm at the time. It was also noted to be the female's responsibility to know her safe days and avoid pregnancy. Amongst the caregivers, it was the mother's responsibility to teach their girls not to get pregnant. The emerging norm was that of pregnancy intention, where young girls would have peer pressure to get pregnant after seeing their own peers getting economic support or some sort of emotional value in their relationships from their sponsors or partners. Poverty propagated risk, exposure, and risk-taking behavior. Amongst the exposures the girls faced were early marriages that would lead to early teenage pregnancy, or when they got pregnant, then they would be married off early. Other risks identified included multiple partners, transactional sex, the use of drugs and alcohol, and violence. Challenges that were identified included lack of access to services, where information as a service was largely lacking for many adolescents. Also, lack of access to services such as contraceptives, HIV prevention interventions, and GBV services. While Kenya also has a large pool of policies, guidelines, and legal frameworks for implementation of these policies, guidelines, and legal frameworks, as well as lack of resources, contributed to the issues that we see. From this study, therefore, the girls who were perceived to be more likely to get pregnant were those from poor households, violent households, those who were unable to carry on with studies, those who were living in female-headed households, and also from the Some of the key recommendations that came up from this study were the need for stakeholder mapping and engagement, for well-coordinated and well-resourced adolescent-responsive programs that target both boys and girls. Other than support for school re-entry or linkage to employment opportunities, policies that support the care and survival of children born to adolescent parents are required. Enhancing differentiated and integrated service delivery models or program models, the need for innovative models for messaging and information sharing were noted. Scaling of HIV sensitive or quote-unquote young parent-sensitive social protection interventions would be an area of consideration, as would be the engagement of parents and communities in enhancing programs for young parents. Thank you for your attention.
Thank you so much, Teresa. Some very important considerations there for policy, services, and also addressing social norms. Really appreciate that presentation and the insights. I encourage you to download that report. It's hugely rich and has a wonderful depth of findings. Teresa did an amazing job today summarizing it into 6 minutes, but do yourself a favor. It's a fantastic read, really rich and provides many perspectives. Thanks, Teresa. We're now going to turn to Nontokoza Langwenya. Nontokoza works for Oxford Research South Africa, where she co-leads on the Hey Baby cohort. Her research to date has centered around women's reproductive health and HIV. And today she's going to share with us some of the latest findings of their Hey Baby cohort from the Eastern Cape.
Thank you for the opportunity to present today. I'll be focusing on sexual reproductive health and well-being of adolescent mothers. And these are findings from the Hey Baby study, which is work led by Dr. Lucy Kluver and Dr. Eleanor Tuster, based at the University of Cape Town and Oxford. The Hey Baby study is a cohort study of adolescent mothers, so adolescents who had their first child when they were between the ages of 10 to 19 years. It was important that we had adolescents from all areas of the community, so those who were engaged in care and those who were not engaged in any of the services. So we did spectrum sampling. We had recruitment at clinics, schools, we had door-to-door activities, and we asked referrals among those who were already part of the sample. In total, 1,046 adolescent mothers now form this cohort. 30% are living with HIV. Who are our adolescent mothers? The average age at birth of the first child was 16.7 years. Overall, 1 in 10 have had their second child. And when we look at adolescent mothers living with HIV as a subgroup, this proportion doubles. Majority are caring for their children, spending at least 4 nights of the week with their child. Most of the pregnancies were reported to be unintended pregnancies. A third of our mothers have already experienced intimate partner violence, and less than a quarter of adolescent mothers received the recommended ANC package, which is an ANC visit at each trimester or a total of 4 ANC visits before giving birth. We asked our adolescent mothers about the fathers of their children. 46% reported that they were still in a relationship with the father of their child. What is concerning is that nearly half of adolescent mothers reported that they did not know the HIV status of the father of their child. And this is quite an important sexual reproductive health indicator when thinking about HIV prevention and the transmission of HIV to sexual partners. The use of contraceptive methods can help avoid unplanned pregnancies in the future. The graph on the left shows the rate of hormonal contraceptive uptake at the time of baseline interview. In blue are adolescent mothers who are compared to their peers in gray. We see that hormonal contraception uptake is higher for adolescent mothers compared to non-mothers, regardless of their HIV status. However, when we look at condom use, we see the opposite of the graph on the right. Adolescent mothers are less likely to report condom use at last 6 compared to non-mothers. And this is the case for whether one is living with HIV or is uninfected by HIV. As you may be aware, being an adolescent mother is not easy. The graph here shows the proportion of our participants who experience some form of mental health disorder, anxiety, depression. And this is disaggregated by whether or not someone is a mother or a non-mother, as well as by HIV status. What we can see is that adolescent mothers are more likely to have worse mental health outcomes, and that this is even more so or pronounced if the adolescent mother is living with HIV. Stigma as well is of great concern for adolescent mothers who are living with HIV. Our qualitative work also spoke to some of the practices that our adolescent mothers were doing to avoid stigma. We don't walk around during pregnancy with an unborn baby, says an adolescent mother, because the witches might curse the baby. They only leave the house to go to the clinic or if there's an emergency. We also examined what could reduce sexual health risk and not just have impact on one factor, but across multiple sexual risk health behaviors. Food security came out as one of those that could have multiple impact in reducing sexual health risk. On the left, we see the impact for those who are not yet mothers. It reduces transactional sex, multiple sex partners, and more likely to be enrolled in school. When we look at our adolescent mothers on the right, we see that food security has even a greater effect on the reduction of sexual health risk.
Fantastic, Nontakoza. Your cohort data once again revealing to us so many important considerations for programs and services for this population. Thanks to you, Lucy and Alona. So I just want to bring us to the Jamboard, where a number of you have shared your experiences of either being a young mother or supporting a young mother. So a number of the experiences already echoing what we've heard in the first section of this webinar. We see here the discrimination at the different levels, the impact on mental health from the HIV status as well, that we treat them like adults during ANC, even though they are adolescents. Many of them don't get the support from the family that they need. The need for psychosocial support, the need not to judge them, to be a professional clinician, making sure that we are integrating services and making sure they have access to all those services. So thank you to everybody who has contributed. All right, that brings us to the end of the first section of our webinar, focused on really understanding the perceptions and the experiences of adolescent and young mothers. We'll now be moving on to the second part of this webinar, where we will be exploring a model that is showing great promise for adolescent mothers in this region. And this is the community-based or peer-led model that's known to many as mentor mothers or young mentor mothers. To start off with, we're going to share a video from Malawi that really brings this model to life.
Zinanga ndilekise kisale ndiyindizaga 19 ndi pabanja ndi mwana mmozi. Mu 2017 ndinalowembelezera ndipo ndinanyamuka kuyamba sikulu kuchipatala. Nditapita kumeneko ananena kuti kaizisa magazi ndipo ndinakaizisa magazi. Akandiza magazi napezeka kuti ndine kachirombo. Enabe ineyo sinimakhala osangalala bwino yayi ndimakhala nthawi zina osankhula ndi munthu pakazi pakalo ndi vuto limene akangati bambo mapasa ngati busy kwambiri. Titabwera kumeneko anawuziza kuti apiteko mu October akaizisa okay ndine kandifusa.
Kudera athu achinyamata ambiri akumana ndi mavuto monga kugwiriridwa komanso kusapeza mwayi wa ntchito. Dzina langa ndine Chimwemwe Yakimu, ndimagwira ntchito ngati community mentor mother. Tikamuyendera tikampeza kuti sanapite kuchipatala wamisa, timamulimbikisa ubwinonso upite kuchipatala. Ndipo akakhala kuti mwina ndi okanika kuti iye maganizo ake asanavomereze kuti ali pa mankhwala, timamulimbikisa ubwino kumwa mankhwala mwa ndondomeko, timampasa zitsanzo zoyenera kuti mwina
munthu amene atandiwuza kuti akazi anga apezekane kachirombo ndinaganiza munthu amene chimene chandisindisa kuti ndasebanja chifukwa pakati payo ndine panalibe ma mistake osiyanasiyana monga ngati mmene timakhala sitimapezerana vuto lililonse. Nde chinanditengeranso ine mumtima mwanga kumva nazonso chisoni kwambiri kuti ndimulakwira kutheka kuti akhozoganiza maganizo olakwika kwa iye kuti mwina mwake tisadzathe kuzaonananso.
ali madiscordant ndi kukambirana nawo za umoyo wa kumene ungayendere. Zimenezo zimachitika oyamba sindani siwo alikonso anthu ambirimbiri.
Ndinalibe kukhumudwa kanthawi imene koma nditangoyamba kumwa zonsezo zinatha chifukwa nkhawa zonse ndinazitaya. Ndi mmene amayankhulira Chimwemwe amandilimbikisa kuti mwana yazimwa mankhwala mwa ndondomeko usati mzidumpisa iyayi mpaka zafikire kuti watani wasiya kuyamwa.
Timakhoza kusowera nawo nkhani kuti tikamuuza ndani koma tikamfotokoza chilichonse chimayenda bwino. Sakondanso kumwina kuwauza anthu ena amakhala kuti wachikhazikitsa mmoyo mwake banja kumakhala mwamtendere kupyolera mwa iye mwina mukamphiri kuti iye palibe zativuta.
Ndimalota kuti mwana wanga sazatenga naye kachirombo.
Mwana wanga uja ndimamukonda kwambiri.
Ine ntchito yanga ndimayikonda chifukwa kuti sindimadziwa kuti bungwe la Mothers to Mothers limalimbikisa kuti munthu ukhale pamtendere ngakhale uli positive. Komanso mladera mwathu talimbikisa anthu ambiri amene samadziwa kuti akazulula akhoza kupeza chithandizo mwachangu. Pali ena oti samakwanisa kuzulula amakhala kuvutika koma chifukwa kuti anazulula tabwera mdera ali pamtendere pano sakumadwalaso amene amadwalira kale.
Powerful stuff. Thank you so much for that video, Mothers to Mothers and Malawi, UNICEF, and to that family for sharing their story with us. We're now going to hear from Evelyn Mitetwa. Evelyn is the Young Mental Mother Coordinator at Africa Jandiri in Zimbabwe. Evelyn is a nurse and a public health practitioner. She today is going to share with us their adapted, well-known community adolescent treatment supporter model, otherwise known as CATS, and how they're using that for young mothers.
A good day to you all. My name is Evelyn Mtetwa. I'm presenting on the Young Mental Mothers Initiative, a national response in Zimbabwe. I am with Jandiri. The YMM intervention is adapted from the CATS intervention that Jandiri is well known for. The CATS intervention, which is evidence-based, has been scaled up in Zimbabwe and in the region beyond Zimbabwe. Out of this CATS model were born the young mental mothers. These are young women, 18 to 24 years old. They are living with HIV. They are mothers themselves, having gone through pregnancy, labor and delivery. They are trained and mentored by Ministry of Health and Child Care together with Jandiri as peer counselors. The young mental mothers case manage mother baby pairs at home, at the facility, during support group meetings, and using digital health. The roles and responsibilities of the young mental mothers are across the Start Free, Stay Free, and AIDS Free cascade. Where under Stay Free, they offer index case finding for young mothers' partners and their children, PrEP demand creation for HIV negative partners. Under Start Free, they are doing adherence counseling, monitoring and support of pregnant young mothers, linkage to EMTCT services, follow-up of mother-baby pairs, linkage to early infant diagnosis using the national algorithm, then follow-up in clinics and homes until cessation of breastfeeding has taken place and the baby has received the final outcome. Under AIDS Free, the young mental mothers form mother-baby pair support groups. They provide weekly home visits, SMS reminders, adherence counseling and support, mental health screening with problem discussion therapy to those that would have screened positive, linkage to viral load testing, as well as linkage to SRH services. Results so far for the moms and their babies. The 72 young mental mothers are supporting 1,671 mother-baby pairs in 38 sites across Zimbabwe. They are providing enhanced counseling and problem discussion therapy to the 1,671 mothers. Although we are still collecting mental health outcome data, we have found this same approach delivered by CATS resulted in a reduction in common mental health disorders from 62% to 2% among adolescents living with HIV. So this is the same approach that the young mental mothers are providing to their peers. So it's not only about identification of common mental health disorders, it's also about problem discussion therapy, where they provide a platform for their clients to discuss with them, work out solutions that might be relevant to the situation that their clients might be in. Those clients that might then be requiring a referral for other services beyond the young mental mothers, services are then offered and referral is done. Moreover, the young mental mothers have also been involved in ensuring that 96% of the young mothers they are following have an undetectable viral load, with 97.6% of the exposed infants coming out HIV negative, 2.4% EMTCT rate at the end of breastfeeding, which is quite low as compared to the national average that we are having. Successes have been recorded in terms of engaging men. 65% of young moms reported having a partner. Then 92% of those partners tested for HIV for the first time. 66% were identified with previously undiagnosed HIV. 99% of those HIV positive were successfully initiated on ART. 98% of those that tested negative were subsequently linked to PrEP services. There has been a significant improvement in disclosure by young mothers to their partners, because once the young mental mothers have linked with their primary client, who is the young mom, they then extend their services to the partner, who then accepted the services after seeing, of course, the positive outputs that the young mental mothers were having on their wives or spouses. Strengthening of system has been at the backbone of the Young Mentor Mothers Project. It has actually been one of its major strengths. There's been integration of young mentor mothers within EMTCT plans at national, district, and site level. Joint development of young mentor mothers training and implementation guidelines by Ministry of Health and Jandiri. Training and mentorship of healthcare workers, ensuring adolescent-friendly HIV and PMTCT services. Primary supervision of the young mentor mothers is done by the healthcare workers at the facility. Integration of young mentor mothers across different entry points in health facilities to ensure no client is missed. Referral system for other services beyond health have also been done, particularly mental health, gender-based violence, and sexual and reproductive health. The young mentor mothers have also been involved in real-time data collection and reporting directly into DHIS2, a platform that is managed by Ministry of Health and Child Care, as they enter their data directly into that electronic mother-baby care register. What are the next steps? Continued scale up to new districts within Zimbabwe, strengthening the role of the young mentor mothers in integrating contraceptives, scale up of mother-baby care registers, and tracking outcomes, PMTCT as well as mental health. Increasing focus on partner intervention, scale up of income generating initiative for young moms, as the young moms have come out very loudly saying they would require income generating initiative to ensure that they become financially independent and be able to support their families. Also looking at the situation that the country is currently in. Technical assistance to other country wanting to adopt the YMM intervention, just as like the CATS intervention was scaled up beyond Zimbabwe. Continued linkage of graduating young mentor mothers to future employment so that all the skills and technicality and technical things they've been trained are not lost when they graduate out of the intervention. This brings me to the end of my presentation. Thank you very much. Jandiri, one model, multiple partners. Thank you.
Great. Thank you, Eve. Wonderful to see how you've adapted CATS for young mothers. It's fantastic. And also to see how you're working to strengthen the health system as well. Wonderful stuff. All right, that brings us to our next presentation and our final presentation for today's webinar. We're now moving to South Africa. We have Oti Muhlungo, who is the Deputy Director of PMTCT at the Provincial Department of Health in KwaZulu-Natal in South Africa. Oti is going to share with us their experience of implementing mentor mothers for adolescent girls and young women.
Of my presentation, I will do introduction, mentor mother model, outcomes, scaling up of the program. There are 9 provinces in the country, with 7 of them implementing the mentor mother model. UNICEF South Africa has provided technical support in 4 districts in 2 provinces, 2 in Gauteng and 2 in KwaZulu-Natal. Technical support to National Department of Health is provided by M2M from 2019, funded by UNICEF South Africa. In Gauteng, the mentor mothers are employed by Department of Health, and in KwaZulu-Natal, they were recruited by. The context in South Africa for AGYW, 36% of South Africa's population is youth, with 18.8 million women and girls living with HIV. Most of AGYW not in schools and are unemployed. Most pregnancies are unplanned and unwanted. There's double stigma at both community and facility levels, with nearly 870,000 new HIV infections among women every year. The mentor mother model is a peer-based mentoring and service provision model which employs and recruits HIV positive adolescents, young girls and women who know their HIV status, have experience of being mothers, young mothers, and are willing to disclose their status. The implementation is within an integrated MNCHH and nutrition, as well as HIV services. Adolescents, young girl and women engagement is done, linking into the youth-friendly services in facility and in the community. The multisectoral implementation of the program is based on the social cluster of government, working with Department of Social Development, as well as Department of Education and Department of Health. The service platform, how then is what are the service packages that then are offered by the mentor mothers? There's group health education that is done, whereby the mentor mothers are part of that, working with either community healthcare workers, lay counselors in the facilities or in the communities. They disclose their status, they empower and allow the clients to then come to them to have more learnings. They then have one-on-one education as well as psychosocial support, couples education and psychosocial support. They provide client pre-screening on TB, STI, gender-based violence, mental health. They form support groups working with the other cadres in the facilities and communities and young women's club. They provide referral and linkages with the services that the young girls and women might need, like the police, the social workers, social SASA, and they also provide linkage to Mom Connect, which is an SMS service that is provided to send messages to pregnant and postnatal young women and women that have delivered in South Africa. They provide active client follow-up because they know the clients and they build relationships with the adolescent. For the mentor mother program is access to and uptake quality adolescents and youth-friendly HIV and PMTCT among the WHO services among pregnant and postnatal adolescents and young mothers. The objectives are to increase HIV prevention, testing, treatment, and care for pregnant and postnatal HUYW, to improve early infant diagnosis among the category as well as child care among babies and babies born to HUYW, to improve treatment outcomes, for example, retention and care and violence suppression among HIV-infected HUYW and their babies, to improve linkages and bidirectional referrals among HUYW service providers, both health and non-health service providers. What are the outcomes that we have seen with the implementation of this program is that we had a target of 9,945 for this UNICEF funded supported project. This is data from the facilities that had peer mentors in the 3 districts. From this target, we have achieved a target of 25,288, with antenatal enrollment being higher in all of the districts. The process outcomes in terms of 90-90-90, all the districts where there were peer mentors achieved the 90-90-90 targets, except for Tshwane in terms of initiation on ART, as well as retention and care postnatally for 12 months. This data depicts the data from KwaZulu-Natal, which is from the web DHIS, and it is for all pregnant women, not necessarily adolescents. It is showing an improvement in terms of these indicators, key indicators. The viral load done at specific interval, we're seeing an improvement. Tested birth uptake after the implementation in February 2020, there was an improvement as well. There is some noticeable improvement again in terms of antenatal clients initiated on ART. In terms of scaling up the program, National Department, with the support from UNICEF South Africa, will be conducting an evaluation of the program advertisement for the consultant to do the evaluation is out, and following the evaluation, the National Department of Health will then look from the results and include the plans are to include the mental mothers as part of the national policy. Partners have been trained to implement and train peer mentors and ongoing technical support from M to M. National Department is using departmental healthcare workers and lay counselors in 4 provinces already. This will assist to be able to then scale up. Steps to appoint peer cadres and remove the discriminatory clause so that we're able to recruit from the communities those that are HIV positive and not like seen as being discriminating against those that are HIV negative. We can use the conditional grant in South Africa for the PMTCT program to then recruit these cadres. PEPFAR partners have been engaged to include the peer mentor mothers in their budgets as well as their recruitment plans, because then we can be able to implement this critical program throughout the country. I would like to acknowledge KwaZulu-Natal Department of Health, National Department of Health, UNICEF South Africa, M2M South Africa, as well as CDC. Thank you very much.
A great example. Thank you so much, Oti. Very important scale-up considerations there that we really are excited to explore a bit further in our panel discussion that is up next. It is now my absolute pleasure to hand over to Maximina Jokanya. Maxi is the Her Voice Fund coordinator for Y+ Global. She's based in Zimbabwe. Today, Maxi will be hosting our panel discussion with all our invited speakers. Unfortunately, due to some connection issues, Nondokozo won't be able to join us, but Alona Tosca will be in her place for the panel. And also Miriam is unfortunately unable to attend, but we have Rabina who will be representing adolescent and young mothers in the panel. So thank you to you all, and we look forward to this discussion.
So you can hear me very clearly, right, Alice?
Yes, we can hear you.
Okay. I was worried you can't hear me. Okay, so thank you so much. So as we know, being a young girl, being a young mother, you have recently been tested and you found that you were newly diagnosed with HIV. At the same time, you are new in terms of getting pregnant, and you're really trying to really balance in terms of getting on treatment, really balancing getting used to the pregnancy. All those challenges that really comes with pregnancy, all those challenges that really, us as young mothers do face in terms of, stigma that is in the communities. I'm sure you've heard from those presentations that even Babi Ray actually highlighted during the video as well. So it's really good that we are in this platform to really expand, to really understand and have a way forward in terms of how we can really respond to the challenges and how we could really make the process, and also the interventions of young moms to be able to live better, to cope better, to live fulfilled lives at the end of the day, because that's what we want at the end of the day, really. So I'll just jump into the sessions. Thank you so much to the panelists. I'll start with Babi Ray to really explain to us, you are a young woman living with HIV, you are an advocate, and you recently have a baby. Can you tell us more in terms of what services should do to further support adolescent mothers as well? Thank you. Over to you.
Thank you so much, Maximina. I hope I am loud and clear.
Very loud and clear.
All right. Yeah, thank you so much for that wonderful question. Maybe just to being a young mother living with HIV, I mean, there is more to just art services. I mean, we need more of integration of services, because I, for one, got services from 2 different clinics, both antenatal and art services. So I think integration is really key when it comes to family planning services, when it comes to mental health, when it comes to counseling and guidance, when it comes to art services for both the mom and the baby. And then lastly, the postpartum care, when it comes to breastfeeding, what should a young mother have? And all these services should be at least in one facility, at one center where someone can access them in a youth-friendly manner. Thank you.
Thank you so much, Baby Ray. I think it's really important. They've brought a very important point where we say that, integration is very important. I am a young mother. I don't have all the time in the world, I need to go at one facility. It's a one-stop center for me. So I really need to have all the services available for me at the end of the day. So thank you so much for that insight. So I'll just quickly rush to Elona. I think, are we able to see you now? I'm sure we are able to see.
I hope so.
Yes.
Hi, Maxi and colleagues. I will try to be non-tokosa the best way I can.
Not a problem, not a problem. Thank you so much. So in terms of, what Tokos was also sharing in that study, in terms of, contraception, the issue of, access to services, etc. The evidence really showed the importance, of address the need for us for adolescent young women to have access to contraception, really. Could you really expand on how we could really approach this for our young mothers to have more access to these services at the end of the day?
Thank you, Maxi and colleagues. This will not be new to all of us who are new mothers, even if not young mothers. But with young mothers, I think the most important element, especially with contraception, and we saw that switch from condom use to hormonal contraception and potentially to different types of methods within hormonal contraception, is the need for not to overuse the word, but almost a life course approach. So to think about the mother as they go through the pregnancy, where they obviously would interrupt contraception methods that they may be in, but would still need to continue condom use, to potentially the breastfeeding period and how they understand and they deal with breastfeeding amenorrhea and accessing contraception during that time, and what's happening as they engage with the healthcare system at each of those stages. So in South Africa, but I think this is true from data in other countries as well, a lot of young mothers have nearly 100% contraception post-birth, meaning like they're in the facility, they get an injection, but there's huge drop-offs after that. And as we have just heard today, but we're also hearing from the young women in our study that Non-Tokosa started to share, we have cases of young mothers who are really going to facilities and being given second or third appointment dates for contraception, especially during COVID-19 pandemic, and asking for the method that they need, and they're not getting it. So even when one is proactive and finds the time and childcare to actually get to the method mix and offer is not always available. And ultimately, it's about being as human as possible. I mean, there's sleep deprivation, there is, hunger, there's the stress of getting nappies or, cloth or usable and baby bottles and breastfeeding and all of those. And to think of contraception as just one of the things that someone has to keep an eye on and to just offer that service and expect young mothers to take it up with that in mind.
Thank you so much. Thank you so much, Elona. You have brought up really important aspects when it comes to what more we can do and how we could also approach to this. One thing that I also liked is that the issue of method mix. I think it also goes to speak more of the choice of a young mother. If I have different method mix, I have a choice to make, and I'm able to access whatever I want in terms of my rights as a young mother at the end of the day. So really, thank you so much for bringing that up, really. I just wanted to check, do we have Precious on the call? I can't really see her on my screen.
Unfortunately, she can't connect. So just Precious and Miriam, the two other young ladies, were unable to connect.
Okay, all right, that's okay. So let's move forward then. I'll definitely have to jump to Teresia. Thank you for joining us, and we have really done a great study that we have actually heard from you. You have talked about the importance of multisectoral approach, because we know that young mothers do face a lot of challenges in terms of violence, in terms of poverty, not access to education, even access to any other services for this population as well. So can you really share with us what do you think is required to ensure stronger multisectoral actions? What can we do in terms of collaboration, partnership, in your own insights? Thank you.
Thanks, Maxi. I hope you can hear me.
Yes, you can.
Okay. Thank you for that question. I think the answer, we have the answer, and we've been talking about it for a while now. It's really to come together as multiple sectors, recognizing that adolescents fall under several sectors, like you've mentioned, under education and the health and the social services. They fall under several sectors, and each sector has an understanding that each sector has a role to play. So one of the things that we're trying to do in Kenya is really to take a step back and try and look at adolescents using the same lens. So all sectors bring in the data, and let's look at the girl who is in a refugee camp, for example. What are her needs, and understanding it all together, coming together and bringing it, the evidence together. And a possible way of responding to that in a multisectoral approach would be using the socio-ecological model, for example. So where you have your adolescent as an individual, what are the things that they can do? How can they contribute? How can their peers around them contribute? Their families, then the community around them. And community here would also include the digital space, and along with the other societal and organizational facets that would come together. So I think just understanding what kind of interventions can we put along in that whole chain would help us to have a better understanding.
Okay. Great. Thank you so much, Teresia. Sorry we lost you in I think the last part of it, but we heard you very clearly. You talked about the importance of us recognizing young moms as diverse as we can. They have their own unique needs. So if we approach it in that way, I think we'll be able to help. And also in terms of having multiple services for them, it is really important, like you highlighted as well. So really thank you for that as well. So I just jump in to Oti. Oti, you have shared the study that you did, and we really appreciate all the work that you are doing. We really want to reach out to more adolescents, young mothers that are out there. We are running with the theme that we are not to leave anyone behind. So we are saying that we need to really reach out to as many as we can. So in your own experience and insights, what are the important considerations for you as the National Department of Health as you look for further scale up in terms of the mentor mother models as well? Over to you.
Thank you very much. As I've said in the presentation, that the National Department of Health has summoned an evaluation for the Mentor Mother program in the country. So as soon as we have the results from there, we'll be able to then scale up. But from the learnings I'll start from Tshwane, what was done in Tshwane. We've learned a lot from Tshwane, which looked also into the issues of integration of services for the adolescents and young women, so that they are given services within the MNCHH cascade rather than being referred to the ART. We've learned so many things. And then when we come to KZN, we've learned that we can have the other PEPFAR-funded partners to implement and recruit the mentor mothers. Just like in 2 districts in the province in KwaZulu-Natal, in Zululand and Utukela, HST, who's CDC funded, has moved on to recruit peer mentors. So we will be starting in those 2 districts soon. But what is key is then to have the government being able to recruit that HR practices, people will say we're discriminating against the people that are HIV negative if we're recruiting HIV positive peer mentors. So if we can remove that and let then the HR, the DPSA allow us to be able to recruit HIV positive young adolescent girls, then we will be able then to move and recruit and be able then to sustain. I've seen in the chat box, someone was asking about sustainability, because funds will not always be there from our funders. Much as we really appreciate what UNICEF South Africa has done for us as a country, but it is important that as government, we take then the lead and take the steps. In the meeting we had in May, we had our national counterpart together with a UNICEF support person, and we pleaded for us to be able to recruit, not because it's not that we don't have funds. In South Africa, we've got conditional grant that is set aside for the CCMT program. So we can put this program in the CCMT program, in the conditional grant, and then we can recruit. So there is one area that we can move on and be able to put the adolescents, the young girls in the forefront who are HIV positive, to run and manage and support their peers. Thank you very much.
Thank you so much, Oti. You know why I'm smiling? Because, you know, one thing that we lack in our programming and where we are failing so much is the issue of sustainability, the issue of commitment from the government itself. Because we are saying this is our community. We, as the government, are supposed to commit, you know, have a political will to each and everything that we are doing within the countries in terms of HIV response. So I'm really smiling that you are in the response, you are leading the response, and you have shared with us the importance of having government backing up every program that we have in terms of young mothers. And the important key that you also highlighted is us prioritizing young mothers as a program by itself. We don't need to put it under, you know, the umbrella of PMTCT or the umbrella of, you know, a broader kind of, you know, initiative. We need to have a separate one that is tailor-made of, you know, having a young mother, because they've got their different needs that we need to really address. So really, thank you so much, Oti, for that. Are you around? I can't see my screen. If you are there, can you just shout? Or she has dropped off. We would love to hear from you, Eve. Okay, so while I'm waiting for Eve to come back, you know, we really need to you know, to have a bit of follow up in terms of, you know, oh yes, hello. I was waiting for you, my dear. Thank you so much for joining in. I know you have presented on such an impactful model that you are doing in Zimbabwe, and we are really fond of it, especially myself. I'm a fan of Jandiri. So you know, it's really responding from the front, from the center, and it's really supporting and linking the community to the clinics as well as you have shared earlier on. So can you share with us how have you approached institutionalizing, peer providers and also supporting them? How have you done that so that we learn more from what you have done? Eve?
Hello, Maxi, can you hear me?
Yes, I can hear you now.
Maxi, can you hear me? I have to turn off my camera now. Okay,
yes.
Thank you so much. I think my apologies. I'm in the field and my network is a bit shaky. So what has been the greatest strength for us has been that that's model into the Ministry of Health and Childcare to an extent that the training, the mentorship, the supervision of the community adolescent treatment supporters actually works well because it is being supported by Ministry of Health and Childcare. So when the young mentor mothers then came on board, they simply went to continue with the good evidence that we had already seen from the kids working very well with Ministry of So
you are breaking
lies with the Zimbabwe Ministry of Health and Childcare. So likewise, whatever they do, the accountability lies still with ministry. So whenever we have such ownership, even in instances, can the chat box. Hello, Maxi.
Yes, yes. You are breaking up a bit, my dear.
Okay, so maybe what I just wanted to say is when there is ownership of the ministry, the line ministries, the uptake of the initiative becomes very easy because the supervision is done by them. And in case when we run out of funding, we understand and we know that ministry will take it up like they are doing under the CATS program, where the National AIDS Council and Global Fund are taking on part of CATS, like they would help stuff.
I totally agree with you, Eve. Thank you so much for sharing those insights. So Eve was really highlighting the importance of ownership by the ministries, especially Ministry of Health. Everything has to be done in partnership. So every model that we're employing as partners, as donors, as implementers, let's make sure we have, buy-in from the ministries, just like Otto was saying that, it's on our owners as government to take up this in terms of sustainability at the end of the day. Like Eve also was sharing that, funding might run out, and we need these models to keep running at the end of the day. So, it's very important for us to have that kind of ownership at the end of the day. So thank you so much, Eve. I just wanted to highlight that we are a little over the time that we anticipated to end our call. I hope you can stay with us a little bit more. I will not take much of the time. I think I'll hand over to Ali, I think, so that she could guide us in terms of way forward. But this has been really interesting, hearing from the young moms themselves, hearing from implementers at the end of the day. So really, they've brought up important issues in terms of, social support is also very important, institutionalizing our peer mentors, our peer mothers, so that they are also part of what is happening on the clinic. There is community buy-in, there is government buy-in at the end of the day, and also treating young mothers as unique, as diverse as we can, so that we really address the needs that they have at the end of the day. The importance of having differentiated self-delivery for all those young moms is very important as well. So really, thank you so much. And also, Baby Ray also shared in the importance of integration. I'm a young mother. I want to have my services at one-stop center. I don't have much time in the world, so I really need to access everything in one place at the end of the day. Ali, over to you.
Fantastic, Maxi. Brilliant. Thank you so much to our host, Maximina, and to our presenters. I realize that there were some questions in the chat. I think some were already answered by default in the questions that we had in the panel, but I encourage the speakers to please do, if you have time now, maybe respond to some of those in the chat as well. That would be fantastic. So thank you so much. It's now an opportunity for us to close off the session, and I'd like to invite the Regional HIV Advisor, Laurie Goulet, who's just going to give us some closing remarks. Thank you, Laurie, and thank you to everybody for bearing with us with all those technology issues. Thanks so much, everyone. Will it not let you unmute? Okay, let me try again. I think there's a conspiracy against me. Let me just find you, Laurie. Okay, can you try now?
Yay! I love the solutions-oriented approach. Let me start by saying, wow, that was an incredibly rich and inspiring session. We have heard lived experiences, research, cohort data, latest programming evidence, system strengthening, and practical considerations for working together with young mothers to improve outcomes for the mothers and their children. I hope you all enjoyed it as much as I did. Let me start with some thanks before I actually talk about the way forward a little bit. First to dear Alice for her tremendous leadership in organizing this valuable webinar and managing the technology glitches. They are unavoidable, and she handled them with grace and success. And she indeed demonstrated a solutions-oriented approach. Also, first and foremost, sincere thanks to all of the participants who joined today. We had an incredibly impressive turnout, which bodes well both for our collaboration and progress moving forward. To all of our fantastic speakers, panelists, moderators, and everyone, we really appreciate not just the work you did to prepare for the webinar, but the work you are doing and so graciously shared with us. A special shout out to our 3 speakers that shared their personal stories with such openness and brilliance. Also, many thanks to our funders and implementing partners, and I would like to especially acknowledge the government of Sweden and their visionary and abiding partnership through the Together for SRHR program. Now, in terms of the way forward, we can all, and we all do, strongly agree that adolescent and young mothers living with HIV and HIV-free have the right to correct information, quality support, and respectful health services that are responsive to their needs, including offering multiple services and multisectoral support. The experiences and learning shared today really build on these ideals. It is unlikely that the global goals for 2030 and the new UNAIDS strategy will be achieved without this work that we have been discussing today. Today from UNICEF, we have shared some of the highlights from our report and the Homa Bay research, and we will hope that you will find an opportunity to really read these further. But we also know that we are excited about a growing number and varied initiatives supporting adolescent and young mothers across the region and beyond. We look forward to robust collaboration together with young women and mothers to move forward in a way that supports tailored, strategic, scalable, and sustainable approaches to this work. We don't want to come out with a bang and then slow down. We want to take this in a way that will really build a system and approach that can be sustained. And I think you all have brought that out so beautiful. So thank you so much. And thank you for your patience and for joining us, and all the very best.
Thank you, everybody.
Thank you so much, everyone. Thank you, Alice, for hosting.
Thank you, Alice. Thank you, everyone.
Thank you. Thank you, everyone, for attending our webinar. Fantastic engagements. Really great to hear so many different examples of work that's happening in our region. We encourage you to download our report, our regional report that highlights many more examples, as well as the ones that you have heard here today.